Mayo Clinic presents
Emergency Medicine Grand Rounds.
Hello and welcome everyone to Always on EM, a podcast about emergency medicine by the Department of Emergency Medicine from Mayo Clinic. My name is Venk Bellamkonda, Venk like vancomycin, and I am one of the two hosts of the show, along with Alex Finch. Both of us are coming to you from Philadelphia, Pennsylvania, where we are attending the Society of Academic Emergency Medicine Conference. I spent all day today in the Leadership Forum and had fantastic conversations and perspectives to chew on from a variety of EM leaders like Dr. Brian Zink and several others. Today's episode is the May Grand Rounds episode, and so we want to wish everyone a happy belated Mother's Day. Also to your mothers, happy belated Mother's Day. We continue to celebrate the amazing nurses as well that devote their careers to comforting the sick around the world, as this is also National Nurses Month. Later this month, Memorial Day 2025, we will pause together to remember the courageous men and women who gave their lives in service to our country. Their sacrifice is the foundation of the freedoms we enjoy today. At Mayo Clinic, we recognize the weight of that legacy and are deeply grateful. May their memory continue to inspire us toward compassion, dedication, and service to others. All right. Let's focus on the content for today's episode. We feature one of the amazing senior residents and future educational leaders of Mayo Clinic, as he is set to join the Jacksonville Mayo Clinic campus after he graduates. That is Dr. Daniel Fiterman Molinari. You're going to hear a great formal introduction by my amazing co-host, Alex Finch, that was given on the day of the Grand Rounds, and that will go over more of Daniel's cumulative background. During this talk, Daniel will share several perspectives that really challenged me to think through how I view the data and how I view the management of cardiac arrest beyond the ACLS algorithm. And I think if you find yourself thinking about what he is talking about, what he's proposing for the days after you listen to the podcast, that's a huge win. And that's why Alex and I want to share it with you. I know you're going to love this. Take it away, Alex.
It's my absolute privilege to introduce today's Grand Rounds speaker, Dr. Daniel Fiterman Molinari. If you know Daniel, you know that he is a force in emergency medicine, a clinician whose dedication to evidence-based practice, research, and medical education is nothing short of extraordinary. But beyond the accolades and accomplishments, he is someone who elevates everyone around him. When he asked me to introduce him, I was reflecting on our first shift together. It was an overnight in the Center 2 pod. At that time, it was just the two of us that were staffed in that pod. And I just remember that patient after patient, we discussed every single test, every single plan, with Daniel bringing up the literature. And when we walked off the shift, he said, "I feel that we truly did the best for our patients tonight." And afterwards, he sent me about 3 emails with new papers that made me better as an attending. And I think that is the essence of graduate medical education. He's collaborative, inquisitive, and always striving for excellence, and sets an example for all of us. His career is nothing short of remarkable. Daniel's journey in emergency medicine began in Brazil, where he completed his first EM residency. He then became a medical director, attending physician, and leader in research and education in Brazil. From there, he took his talents to Israel, where he was instrumental in opening a brand new emergency department, where he was the ultrasound director, director of research, and residency faculty. His passion for education is completely undeniable. He's led countless workshops on everything from airway to our very own ECMO simulations in the ED, where he's advocated for TE in every single one. I have no doubt that he will continue his incredible track record for educational excellence when he starts in Mayo Jacksonville. Today, he's presenting on a topic that is at the heart, no pun intended, of everything he stands for: evidence-based medicine in cardiac arrest. If you've ever worked with Daniel, you know that his approach to clinical care is meticulous, thoughtful, and always backed by data. He's the kind of physician who makes us all better, to think critically, and to push beyond the way things have been done. So please join me in welcoming Dr. Daniel Fiterman Molinari.
Thank you, Finch, for the introduction. I'm very happy to be here. It's an honor to be in the Mayo Clinic, which is an institution that stands for what I stand for, which is the needs of the patient come first, and every life matters. I'm talking about a very interesting subject, which is probably the most fascinating subject of emergency medicine, which is cardiac arrest. And my plan is to talk about some ongoing standards of care that are considered standards of care, and to talk about some ways to challenge that knowledge, and also to discuss some strategies that are evidence-based to improve patient care. We're going to see that some of those evidences are not new, but we just haven't been practicing them for some reason, probably because we're using protocols. Finch is a little taller than me, a little bit. So just starting about the definition of cardiac arrest, it is very controversial. From first Google AI gave me an interesting definition, but they talked about the sudden cardiac arrest, as if it's something sudden and unpredictable. American Heart Association gives also an idea that it's caused by arrhythmia because they're a heart association, so they're trying to blame it on the heart. British Heart Foundation said that, it's when just the heart suddenly stops. But I wasn't very satisfied with that definition, so I created my own definition of cardiac arrest. So my definition was, cardiac arrest happens when the heart stops pumping. I didn't use suddenly. And which would stop pumping blood effectively due to some type of malfunction in preventing blood from circulation to brain, lungs, other organs, leading to unconsciousness, disability, and death if not treated properly. I was like, is my definition good? So I asked a very smart person called GPT, is my definition better than the other definitions? Because I'm a little bit competitive. And they said, yes, it is concise, it is inclusive, and we're living in an era of inclusiveness. So I was very happy with my own definition, so I think you should use it. When we're talking about cardiac arrest, we all know the classic H's and T's and all the different causes of cardiac arrest. We can divide it in also different ways: cardiac, metabolic, ventilatory, obstructive, hypovolemic. Hypothermic, I consider it separate because there is one difference between this one and every other one. And what every cause of cardiac arrest. So cardiac arrest is a presentation from a lot of different causes. And they all have in common that if left untreated, they will all die in about 10 minutes. And the longer we wait to take action, the worse it will be. With that in mind, I'm going to tell you about a patient that I had in 2013 when I was a second-year resident in Brazil. And we had a 30-year-old female who came to the ED with a suicide attempt, unknown substances. Had arrived to the ED, she was unresponsive. She lost pulses at the ED, immediate chest compression, and the highest quality of CPR that we knew to do at that time was done. And the patient got ROSC in about 45 minutes. And what happened is that during that night, she had 7 other cardiac arrests, and she died in the morning. In Brazil, we have an ED critical care, so patients that are very sick, they stay in our ED critical care, and they're managed by the emergency medicine team. What happened that night that left me upset was that everybody quit except me and the nurse. So my consultant was in the room, and she wouldn't come out. She would say, patient is dead. No good neurological outcome. Because the resuscitation has been going on. The first arrest is more than 45 minutes. They're dead. And they tried to argue, and no, I'm experienced. I'm an ACLS instructor. That's the evidence that we have. And she was right. The most updated ACLS at that time was 2010. And there was a recommendation that considering that CPR efforts beyond 30 minutes does not seem to have successful outcomes, maybe we should stop, except in exceptional circumstances. And hypothermia was one of them, but it wasn't really clear what those were. And I wasn't very satisfied with that knowledge, with that concept of ACLS. And I went into ACLS and I saw that it had a reference, which is a very good journal that gave a very bad answer. So there was a paper from New England in 1983 with 58 patients saying that most of those patients died in 30 minutes. So we should maybe not continue resuscitation. And that was the standard of care in that time. So I understand what my consultant was coming from, being an ACLS expert. And looking into more evidence from the time that I was living in, I saw that in 2012, there was a large study on also a very prestigious journal with 64,000 patients that and they were at multi-center cardiac arrest in many hospitals. And we saw that a lot of patients survived after 30 minutes. And it's pretty significant. About 730 patients out of the 64,000 lived beyond that time. And we know that most of the resuscitation time was short. Most of the death happened before that. So people stopped doing longer resuscitation. But the patients that had longer resuscitations, some of them actually did survive. And as I said, when I started talking to you guys, every life matters. So the idea of prolonging resuscitation and saving maybe 1% of patients is very meaningful for me. And so the recommendation that maybe longer resuscitation time, you might be able to save a little bit, one extra person every 100 that we're resuscitating. And then we see that for different types of arrest, we saw that there is from the shockable versus non-shockable rhythm, we had about 8% increase in the VT after 30 minutes of resuscitation, and almost 6% in the non-shockable rhythm, on the PEA. And if you evaluate actually for discharge at survival, that number drops significantly. We see that the patient that survived from PEA was 10 to 12%, and the VF was 30%, very low. But you see that the hospital, the institution that had longer time of resuscitation, increased about 2% the survival rate, especially for the PA. There were no difference for the shockable rhythm, and it does make sense if you consider what the cause of arrest is. But the patients that we are more pessimistic, that are non-shockable rhythm, that we're working them for longer, we can save maybe 2% more. So there is bigger impact on prolonged resuscitation on the patient that arrested for PEA. And that's not a new knowledge. That was a knowledge from 2012.
Can you clarify survival 2% more? Is that survival to hospital discharge neurologically intact and functionally independent, or dependent, or brain?
I'm very happy that you answered this question, because that's exactly what I'm going to talk about, right? So this is survival to hospital discharge. ROSC was higher, was like 50%, 45%, but survival to hospital discharge was a change from 10 to 12%. So there was 2% increase in discharge to hospital discharge. And now the question was, what about neurological outcome? That was the biggest question. And we thought that's why I thank you for reading my presentation before I gave it, so you already knew what I was going to ask, right? So I had to talk to Dr. Carpenter before about this. And the data we had is that the patients that were, so these were all in hospital cardiac arrest. So they were all most of them were monitored, or they had really close follow-up. And then we saw that the patient that actually did survive, they had good neurological performance for in-hospital cardiac arrest. So when we look at the number of patients that survived, most of them are early, some of them with 15 to 30 minutes, but the 730 patients that lived to be hospital discharge, they had very similar neurological performance to the patients that survived earlier. So the idea that prolonged resuscitation reduces neurological performance is not accurate. It is not great, but it's similar to the patient that survived earlier as well.
When is that the figure? What year is that paper taken?
So 12, right? So I actually took this picture of a friend that made a presentation. I couldn't get a better image, but this is good for you to show because he made this graph about actually that's the neurological performance after survival to discharge. And you see that the patient that actually made out of the hospital had similar neurological performance regardless of their time of resuscitation for PEA and for shockable and non-shockable rhythm. There's a bias here, right? The bias is because there's significant lower survival to discharge on the delayed group. So we know that patients that had horrible neurological performance, probably more goals of care discussion were held during hospitalization and they withdrew support. So that's the bias that, so we anticipate that there might have worsening neurological outcomes towards late cardiac arrest because more of them died. But you know that if they actually made out of the hospital with all that process, they can have good neurological performance. So the argument of we're stopping resuscitation because you probably will have a horrible neurological outcome is not a good argument. The argument that maybe it's not a survivable condition, I understand. But that's why if we're going into this old data that we had, we know it makes sense. And this only for the adult population. And then we had that concern is that, about neurological performance. We know that the measurement of neurological performance it's pretty standard but very broad, right? Where we consider good neurological outcome, the CPC 1 and 2. CPC is fully normal. CPC 2 is a patient that would require some type of help with daily activities, but they're okay. And when you go to 3, it's very broad. So we're going to talk more about this. If you want, we have Dr. Ginsberg, who's been an amazing source of inspiration for this presentation as well. So go to the pediatric world, because that was only for adults. We have also data from the same time of 2013 of patients with prolonged resuscitation and good neurological outcomes. And then we had similar results than we had for the adult population, that patients, most of them survived earlier, and we had a very small amount of patients that survived after 35 minutes. About 16 patients survived to hospital discharge for prolonged resuscitation. And that goes to the same question. They have prolonged resuscitation. Did it change the neurological outcome? And we saw that there was difference in neurological outcomes. But even though there was a difference, there was a drop in neurological performance from the early, for the short course resuscitation, to the prolonged resuscitation, it's still enough to have 60% of those small amount of survivors with good neurological performance. So even if considering there is a difference in neurological outcomes from the early survivors to the late survivors, it's still good. So I think we should also have prolonged resuscitation for pediatric population as well. And fortunately, in 2015, which was the next ACLS, they took out that part of recommending to stop resuscitation after 30 minutes. And I was very happy about it. I'm not satisfied. I'm not completely satisfied because there were some more things that ACLS I thought they should talk about. And you know that they have frequent updates. They've been doing every 5 years, and they write some short updates, but they have really like each 5 years larger updates. The most recent large book was 2020. Hopefully, you're going to get another big update this year. That's the plan. So when you talk about standard of care and the resuscitation expert, their ACLS instructors, I think we can be better than that. According to the ACLS guidelines and our standard of care, we know that cardiac arrest has horrible prognosis. We know that patients from out-of-hospital cardiac arrest, 10% of them will survive to hospital discharge. And in hospital, about 26. And if we look at this data, we can be pessimistic or optimistic, because 10% is not as bad because we can save that patient. And the survivors are not that neurologically damaged as we thought that they could be. And what I'm being optimistic is that we're getting better at it. And remember that I said that every life matters. So a small impact means huge. There's a Jewish proverb that if you save a life, you save the world, right? So I'm not religious, right? But I'm very in touch with my background, and I believe in it, that if we save one life, we save the world. So small improvement means a lot. So optimistic as I am, as you guys know, I'm aiming to talk about some strategies to try to make it a little bit better and maybe try to save that extra patient. We know that in hospital and out of hospital cardiac arrest are different. And we talked briefly when we talked about definition and causes. There's so many ways to classify cardiac arrest and to differentiate, and we try to didactically explain in different ways. And we already talked about that they all kind of have similar things that they all would need, and if left untreated, they all die in 10 minutes. So there's some similarities in all of them. It's difficult to talk about cardiac arrest and be very specific about each one of those things. So I'm going back to the standard of care to talk about the chain of survival, because it's a fascinating concept, which means that when we're talking about the management of patient in cardiac arrest, we see that if each one of these aspect is broken, the patient will die for sure. And if we have everything connected, that's when the patient has the chance of survival. And we know that if we improve each one of this, at the end, we're going to have better outcomes. Briefly, we're going to talk about something that we usually don't talk about, which is the prevention phase. Because we have horrible prognosis, if we can reduce cardiac arrest, that's ideal. We know that for out of hospital, there's some implantable defibrillators, chest, life vest, keeping dialysis patient in, keeping your hemodialysis. When you discharge from the ED, make sure that they get proper follow-up to prevent chronic condition to progression to deterioration and cardiac arrest. We have some home monitoring programs. And especially for the in-hospital settings where we are working, we have the classic rapid response systems, which is also not new data that it helps. But I'm going to talk about something that we are not doing in our practice, and we think that that there's room for improvement, which are the rapid response system for emergency department as well. So this is a very interesting study from Texas, where they actually use the rapid response systems for different hospital settings, and they used ICU, wards, and ED, and we saw there was a larger impact in reduction of prevention of cardiac arrest for the sickest patients and for the most unpredictable patients, which are emergency departments. And the idea is that the idea of this is creating a systematic approach, empowering the nurse to get the doctor that would make a difference early, which would be either the critical care doctor or the emergency medicine physician. And not only empowering the nurses, but also empowering the family member to skip obstacles and actually get the doctor in the room now So there's a change in culture by switching, instead of the cold team, a rapid response team in the emergency department. And that showed to have significant impact in reducing cardiac arrest as well as mortality. Interestingly, that it did not reduce the number of, in the ED, of patients that went to the ICU, which kind of doesn't make sense, but it reduced mortality. So how can we improve prognosis with the strategies that we have? And we already talked about that by improving neurological outcomes. We're also talking about improving survival and vice versa. They work together. By improving survival, we're improving patients that are getting out of the hospital neurologically functional. And then we go back to the chain of survival, and I'm looking at things that they all have in common. But to understand what we can do, we have to understand what does it mean, what causes neurological damage, and what causes death, because they're all connected. And that's a pretty interesting, and there's so many different theories behind of what happens, and that's a very interesting theory of about clinical pathophysiology of the hypoxic ischemic brain injury. And they talk about a normal perfusion versus a patient that is actually not getting enough perfusion in cardiac arrest. They had a lot of animal models to practice with biomarkers for patients in cardiac arrest. And they saw that there is a few components. One is the microclots. Another one is the cellular damage by free radicals and toxins. And of course, the hypoxic component. And it described very similar of the mechanisms and what causes it. And they all go around the microclots, the decreased oxygenation. They talk about elevated PCO2, changes in oxygenation and PCO2, the shift in oxygenation and PCO2 would also be a component of this neurological damage, as well as a relationship to possible death. So how can we improve it again? So we know that microclots are caused by blood stasis, and we have that, we know it very well from the ECMO world. Right? If the blood stops, they form clots. We see it when we're doing our ultrasound that I love on cardiac arrest. And when we see that we're not doing apnea compression, we see some clots forming. You know, that's horrible for brain and for death. And we also know that decreased cerebral perfusion will also cause vasogenic cerebral edema, hypoxia, cerebral ischemia, and the hypercapnia, and as well as the hypocapnia. The shift in CO2 causes increased intracranial pressure, as well as cerebral edema, cell death from acidosis. And the same model was actually recently, last year, a document from the Neurocritical Care Heart Association describing that same mechanism of the triad of brain, lung, heart during cardiac arrest, how they're directly connected, and the damage of one of them kind of damages them all. But if you improve one of them, you can actually improve them all. So there's a triad. So this mechanism that was described earlier, it's been reinforced today. So I'm happy that we have old data and new data kind of saying the same things. So back to the chain of survival, and you know that they both have in common is the idea of the high quality chest compression, CPR, sorry. And the high quality CPR means basically chest compression and ventilation. And according to ACLS, it tells us to, if you're not intubated, go 30 to 2, and then, or if he's intubated or an LMA, just give it one breath every 60 seconds. And their evidence behind this is very, very strong, which is so strong that it's not existent, right? So there is no evidence of why they do it. There is a lot of opinion, a lot of discussion, a lot of the brilliant minds of American Heart Association had this discussion. And I've heard explanations which does make sense, is that we have to find a way to make it easy so everybody will do it. If we make it too complicated, it's not going to be done. And I understand that. So it's real and it's helpful, and ACLS has helped save lives around the world by teaching everybody the same exact protocol. So I'm not against protocols. I'm against protocols for us because we're specialists. So we have to know a lot more than the protocol says. But for every other doctor out there, or medical students, or kids in school, or bystanders, you really have to, knowing ACLS is great. So doing this is helpful. I'm not saying that the 30 and 2 and the 6 seconds is helpful, but everything else. We have a very interesting study from also old study that has beautiful images that does explain how the perfusion related to chest compression can be seen and how it's changed every time there's a pause in chest compression. So the first image shows you that there's a minimal pause for less than a second just for a ventilation. So it's not for less than a second, that's about 1 to 2 seconds when we give the ventilation, and it shows that it drops perfusion and it takes some time to regain. So you see that the more often you give those ventilation, the more often you're dropping perfusion, and it takes more time to get back to normal. And we have the patient that had a continuous chest compression, it kept perfusion high. We know that they had longer pauses for longer ventilation, they would have longer time of non-perfusion. So this would be an example of the 30 to 2. And the first one would be the during ventilation during chest compression. And 17, we had a very interesting Cochrane review comparing some different strategies of chest compression on mortality. And what was not surprising to me, but surprised a lot of people, is that hands-only CPR and chest compressions alone had increased survival to discharge rates, which were significantly different from interrupted chest compression for ventilation. And then we also saw that ventilation compared to ventilation, which would be either synchronous or asynchronous, they were similar and they were worse than hands-only. So we have here that there's a favor to not ventilate, just keep on doing chest compression, because we know that ventilation is harmful, it gets on the way of the priority. So should we just not ventilate these patients? And we have a very interesting study from 1961, which is a fascinating study that I don't think we were ever gonna do it again. Where we had 30 patients that were anesthetized and they performed chest compression. It was interesting when I talked to Dr. Finch about this study, he knew the guy, right? He knew one of his mentees was one of Dr. Finch's mentor, which kind of explained why he has also some interesting resuscitation ideas. So this patient had, this study compared, they got 30 patients that were anesthetized and neuromuscular blockage, and they did chest compression, and they measured how much tidal volume different airway strategies would promote with chest compressions alone. They compared no airway management, and there was no flow. And their hypothesis was that there's obstruction from the base of the tongue from relaxation of the muscle blockage. So chest compression without any intervention of the airway is not useful. They saw that hyperextension promoted a tidal volume of 53 milliliters, and that endotracheal intubation or an oropharyngeal tube gave a tidal volume of 156 in average each chest compression. That was very interesting because
I'm misunderstanding. So these are paralyzed patients, but was their heart stopped and they did compression?
No, they were alive. They did. That's why I don't think they're gonna do it again this study. So the patients were anesthetized, paralyzed, and chest compression were done, and they were measuring actually their ventilation.
Only for research they were anesthetized and
yeah, right. And then afterwards, if we have time, Dr. Finch has shared with me some fascinating stories about this wonderful investigator, Dr. Safar, right? Yes, right. So what was very interesting is that if we look at the rate from chest compression, which is 100 per minute, and a tidal volume of 156, that's 15 liters per minute. That's an awesome ventilation. So that was interesting. But then one thing that he also tried to do, which is a fun fact, he tried to get patients be hypoxic and try to ventilate, to chest compression their way to hyperventilate, and it didn't work. So I said, so maybe have to ventilate a little bit. We can't use just chest compression to choose hypoxia. But it showed that it was interesting that it was measured. This also study from 16 they used a model which was very interesting. They chest compressions, and they had an idea of perfusion by amount of chest compression, and they compared it with ventilation. So what they did is they actually put a Lucas device and ventilated patients different strategies and checked for ventilation as well as for perfusion. They used amount of contractility of the chest wall as a criteria for it. And we saw that patients that were bag mask ventilation had better ventilation, but they had reduced perfusion on the right. And the CFI 5 and 10, the amount of PEEP that they received during ventilation. You see that the higher PEEP they were given, they had bigger ventilation, but they had reduced perfusion. So we saw here that no ventilation, they had a tidal volume here of 10 liters per minute in this model. And the more ventilation you gave, the worse it got. So we go back, so we just do chest compression, no need to ventilate. But then interesting, there is this animal study that showed that prolonged chest compression, in this model they had within 10 minutes, the amount of ventilation promoted by chest compression dropped over time, which was not seen on the previous study because it was not prolonged chest compression on the anesthesiology study. And the model, they also was not a person, so it didn't break ribs and did not reduce pulmonary recoil. And we have other studies supporting this, that prolonged chest compression, prolonged hands only, keeps perfusion stable, but it drops ventilation. And within 5 to 10 minutes, the ventilation drops by half. So it does start at 150, then it goes to about 70 something. And then after 10 minutes, it drops pretty quickly, and it becomes about 20 to 30, which is not really significant considering the dead space. So how much ventilation should we do during cardiac arrest? How much oxygen does the patient actually need? And how does ventilation interfere with resuscitation? And ACLS, they give us that simple answer without any evidence that, maybe we just give 10 per minute, which the patient is ventilated. That's what you should be doing. And there's no recommendation, okay, but if that, how do you give that ventilation, and how much tidal volume is important, and what are the ventilation modes? And ACLS does not talk about it. And I think it might take them years to talk about it. Because as we talked about, ACLS was not made for ED doctors, it was made for everybody else. So there's this interesting review about, that is, again, as we talked earlier, before we had this talk, that mechanic ventilation is very interesting to me. And unfortunately, we don't do more of it here in our emergency department. But it compares different ventilation strategies on cardiac arrest. We already talked about the passive ventilation and how beneficial it is in the early phases of cardiac arrest, which means the first 5 to 10 minutes, chest compression alone is useful. We already talked about that using only a bag mask ventilation and stopping for chest compression is harmful. So stop doing that. I'm telling you, don't follow that protocol from ACLS because we know that it's harmful and it's not a new knowledge. We've known it for some time. So stop bagging patients that don't have any airway. And now we have a conversation about, which has been widely discussed, about airway management. The patient has either an extraglottic, an LMA, or an endotracheal tube, and which one is better? And this discussion is being held, and a lot of data are supporting the use of LMA for short resuscitations because it doesn't get on the way. But you know that prolonged resuscitations, endotracheal intubation, gives a higher PaO2 and increases reduces their chance on the theory of that we talked about, the pathophysiology of death and the and bad neurological outcomes. By increasing PaO2 and oxygenation, they're also related to increased survival and also ECMO candidacy. So having an endotracheal tube for prolonged resuscitation tends to be better. So the endotrache should not be your first, but should be considered during an arrest. And the question is, now the moment the patient has an endotracheal intubation, how are you going to ventilate? Can you use a mechanic ventilation? Carrie?
Has anybody done essentially manual BVM, but not pausing compressions, just continue to give every 6 seconds?
That's an awesome question. And yes, this has been measured. And what we have found is that larger studies show that people don't actually do what they think that they're going to do. And if you ask them, what did you do? And they look at videos, they did not do what they said that they were doing. So it's not really reliable. Now, personally, because I love this subject and I've known this knowledge for 10 years, that's what I've been doing for my cardiac arrest till recently, right? I was actually, what I did, I had an endotracheal tube and just an oxygen catheter in the tube and continuous chest compression. And we start reducing recoil. I would just connect to a bag, and every time there is a chest decompression, very small volumes. But it's very hard. You need the airway provider to be really looking at the patient chest and be behaving like a machine. But we have a machine. And Carrie, thank you so much. Just like Dr. Carpenter, you made the right question in the right moment. And we have a machine that does it, which is our mechanic ventilators. They can do this for us, right? But the idea of mechanic ventilation is that it's not the same ventilating patient in cardiac arrest during chest compression than every other case. We know that patients are on classic standard mechanic ventilation are fighting the ventilators, and the ventilator would alarm all the time what's going on, because you would be reading every chest compression as a ventilation attempt. Is the patient breathing? What's going on? And is he breathing too fast? So how can we overcome this challenge with the mechanic ventilation? It's just use spontaneous mode. Tell the ventilator, this wonderful machine, yes, the patient is breathing spontaneously. But we know that we don't want PEEP. We want low PEEP, because we know that PEEP of 5 will reduce the perfusion from the chest compression. So we want very low PEEP, 0. I've told RTs here to put PEEP of 0. They're like, no, 0, PEEP of 0. I said, yes, 0. I was able to negotiate and got it to a 3. Okay, I was happy with 3. Okay, but I said no 5, and we got it to a 3, and it's okay, right? What's my evidence for that? There is no evidence of the 3. That was negotiation. That's compromise, right? You have to pick your battles. But it was less than 5, and the patient was on spontaneous mode with low PEEP, and great. I was able to do it here within the walls of the wonderful Mayo Clinic.
And you're now ready to graduate. You've mastered the skill of negotiation, which is half of what you do as a consultant.
Thank you. And then how much pressure? And then we want tidal volumes from like 1 to 200. That's what we want. Each chest compression, because we're having 100 of them per minute. So that's 10 to 20 liters. That's good enough. And but how fast should that breathing go? We have to go very quick, because every decompression, that's the time that wonderful machine that Carrie was talking about has to give that ventilation. We want very low respiratory time, and ramp and some other things, but we can go very quick, low inspiratory time, promoting this, and change your alarms, allowing a ventilation rate of 100, because that's what the patient will be getting. And what's interesting, if you set the alarm of the ventilator to 120, for example, it will also help you with your chest compression, because if you're going too quick, the machine will say too quick. We live in a world of Lucas device, so we don't get to these issues. But if you're doing chest compressions by your hand, how we did it back in the day, you would actually see in your hand the difference when actually ventilation is being given. So that's a talk for a different time. So can a ventilator actually improve ventilation? And is there any relationship with the perfusion? And I was very happy that in 2017, they made a device, this wonderful machine that Carrie was talking about, that was made only exclusively for chest compression, which is doing exactly what we just talked about, that we should be doing, that I've been doing with my ventilator. It's reading the chest compression as a ventilation, and it's promoting 1 to 2 cc's per kilo, which is about 100, 150. And that's enough ventilation and oxygenation. And this ventilator strategy, we can also adjust the FiO2 to prevent hyperoxia, free radical, improve oxygen and CO2, have continuous chest compression, improve survival, improve neurological outcome. That's a beautiful theory, right? We don't have proof of this yet. But as we talked about earlier, I'm very optimistic, and every life matters. So this wonderful device, because it also gave a little bit of improved the chest recoil, it didn't only promote ventilation, but it also helped perfusion. So patients had arterial lines, they had higher perfusion pressures with this ventilation strategy. So we know that heart and lung working together as a team, they do a lot better when they're fighting each other. So strategies that we can optimize chest compression and ventilation, that's ideal. We have the gases, we have perfusion, and it's something that they all have in common in this chain of survival. So that's real and useful for every single patient. So for how long can we keep the patient alive in cardiac arrest? What is the ideal high quality chest compression? So we have an uninterrupted chest compression. We have a ventilation strategy. Is this the optimal way to promote perfusion, ventilation, and gas exchange? Non-invasively, sure. But then we're starting a new world that we're not going to talk about here. But you have this wonderful machine that we're talking about that now Finch is going to be even happier, which is the ECMO. The ECMO and the ECPR, the goal of the ECMO and ECPR is actually to do what we're trying to do it with chest compression and ventilation. So before we get to the ECMO, we have to stick to our basics. Before we talk about the ECMO, because you know what the ECMO does is how can we achieve the optimum perfusion and ventilation and survival with these non-invasive strategies. And we know that if we do the uninterrupted chest compression, optimization of ventilation and oxygenation, we're going to keep patients alive to be able to get definitive treatment, which could be metabolic illnesses, could be infection, could be intoxications like my patient 10 years ago, 12 years ago. Time passes. And also as a bridge to other strategies to keep them alive. Technology is a friend. So for how long can we keep patients in cardiac arrest alive? Indefinitely. If the definition of cardiac arrest is a pump failure and the heart's not working, we have patients walking around with it. What makes them neurologically intact is optimization of their perfusion and circulation. The patients on LVAD have normal lungs, so they ventilate normal. They have a heart doing the pumping. They're neurologically intact. Survival, heart, lungs, and brain. And the patients on ECMO, their lungs don't have to work. We're doing that with the ECMO, okay? And that we can have neurological improvement. Some take-home points is that longer resuscitation can improve survival. And survival is associated with neurological prognosis. So improving survival, we're improving neurological prognosis. And we can be better than the standard. I don't think we should be satisfied with I'm standard. And patients can be alive while they're in prolonged cardiac arrest. And the better we do at the management of cardiac arrest, the longer the patients will be able to survive. So cardiac arrest management, optimal cardiac arrest management, is a bridge for treatment of reversible causes, as well as bridges to possible non-reversible causes, and further conversation with patient and family members about goals of care and decision for continuation and not continuation of treatment. So just to talk about the case that we talked earlier, justifications to stop cardiac arrest management, to stop CPR, should be evidence-based about goals of care, discussion about prognosis, evidence-based, and if it is survivable or non-survivable condition, not protocol. Thank you so much. Again, it's an honor being here and talking to you guys, and I'm open for more questions.
The Always On EM Podcast.
Emergency Medicine Grand Rounds.